Good morning. Today we'll discuss on the topic non-neoplastic lesions of salivary gland. So non-neoplastic lesions are congenital, developmental, functional, they are inflammatory, infectious, obstructive, traumatic, autoimmune, degenerative, non-neoplastic, non-inflammatory and vascular. So we will see one by one. We will see about the congenital anomalies which causes the lesions in the salivary glands. The first one is the first branchial cleft cyst. The second is the polycystic disease of parotid. So in the first branchial cleft cyst, it is the remnant of the first branchial apparatus, which is radiographically tests typical characteristics of benign cyst if uncomplicated by infection or hemorrhage. So we can see the this is how a first branchial cleft cyst will look clinically, and in the CT images we are able to see the cystic lesion here. And anatomically, it has been associated with the facial nerve or branches, and they are classified as type 1. This is the type 1, type 2. Type 1 is associated with the external auditory canal, which is the less common one, whereas type 2 is found in the parotid gland or adjacent to the angle of the mandible and may extend into the parapharyngeal space. So it may have a fistulous connection to the external auditory canal or the skin surface. So that was the first branchial cleft cyst. The next is the polycystic disease of the parotid. It is a bilateral non-tender enlargement of parotid. And the CT shows glandular enlargement with multiple cystic areas. So in the CT we will be able to find, in this case we can find the patient with the bilateral enlargement of the parotid gland, and the CT images shows polycystic areas of the in the parotid gland. So this is a middle-aged woman with a right parotid swelling. For many years, the patient was not having any symptoms, but her main concern was her appearance. So the MRI was taken, and it showed multiple cysts within the gland, and at the time of surgery, multiple microliths were also seen. So this was a case of the polycystic disease of parotid gland. Next, the developmental. So in developmental lesions of the salivary gland, we have aberrancy, aplasia and atresia. So aplasia of one or all of the major salivary gland is a rare condition which may present with severe xerostomia, rampant caries, candidiasis, pharyngitis and laryngitis. And the condition occurs as a part of a syndrome. So mostly the Down syndrome, Decapolis syndrome, lacrimo-auriculodental-digital syndrome and ectodermal dysplasia. So this picture is from a Down syndrome patient who had aplasia of salivary glands. There is xerostomia which is observed in this picture. Next is the ductal atresia. Ductal atresia is also rare, and the condition usually presents in babies or infants as a ranula, and is thought to be due to failure of the duct to penetrate the oral mucosa during development. So it is known as an imperforate cotton duct. So here we can see that baby with the ranula kind of presentation, but here the opening of the duct is not seen. That is the reason for this ductal atresia. And management is by sialolithiasis to create a new duct orifice. So they create a duct orifice for the salivary secretions to come into the oral cavity. That was ductal atresia. And talking about aplasia, aberrancy. So we have two kinds of thing. One is accessory glands, another one is aberrant gland. Accessory glands are ectopic in position, but they have a duct that usually opens into another main duct. So their accessory glands opens their ducts into the main duct, and normally the secretion happens. Whereas in aberrant glands, they do not have any duct system. So what happens? Some of these aberrant glands can form fistulas and secrete while the patient is eating, and others do not secrete but form poristomas. Here we can see a patient who has an aberrant parotid gland with an opening in the extraoral region, and somewhere in between where the normal opening is here, this is an aberrant opening in the oral cavity. So that was the developmental lesions of the salivary gland, the aberrancy, aplasia and the ductal atresia. Talking about the functional, we have already talked about the functional lesions like the sialorrhea and xerostomia. Sialorrhea is excessive production of the saliva, which is due to some autonomic nervous system dysfunction due to some other reasons, and xerostomia is reduced secretion of saliva. It might also be due to some drug-induced, or it can be due to some lesions. And there are inflammatory lesions of the salivary gland, which includes the chronic sclerosing sialadenitis and post-irradiation sialolithiasis. These are the two inflammatory lesions which we are going to discuss in this topic. In the chronic sclerosing sialadenitis is otherwise known as Kuttner tumor. It is considered as a IG4-RD, which is IG4 related diseases. This is a spectrum where there are many diseases included in it. IG4 related disease emerged over the last 2 decades. Previously it was defined as a different entity, and now they have clubbed these diseases into the IG4-RD group, which is an immune mediated condition that unifies multiple fibroinflammatory single organ diseases. So the submandibular gland is frequently involved, and unilateral or bilateral hard masses are found, which is painless or asymptomatic. It mimics tumor clinically and or radiographically. Though the name is Kuttner tumor, this is not actually a tumor. So histopathologically, which is characterized by sclerosis of interlobular septate with accentuation of salivary gland lobular architecture and an interstitial infiltrate by lymphocytes and plasma cells, along with various degrees of sclerosis. And the involvement of adjacent salivary lobules may be non-uniform with focal atrophy and loss of acini in some lobules. Reactive lymphoid follicles and collagenous sheets around the small ducts are frequently seen. So this is the histopathological picture where we can see the sclerosing areas in between, and this is a patient with a Kuttner's tumor and how it appears clinically intraoral. So that is the chronic sclerosing sialadenitis. And talking about radiation sialadenitis. So radiation, the Sirae acini are most radiosensitive, so the parotid is the most affected salivary gland due to radiation. It can be acute and chronic inflammatory reaction to radiation, and degenerative changes in salivary glands resulting from exposure to ionizing radiation usually are consequence of head and neck radiotherapy. So the reason for radiotherapy is the head and neck cancers. So what happens in acute radiation sialadenitis? This happens during or within 2 weeks of radiotherapy, which is transient and inflammatory. It is partially reversible with low dose exposure. Whereas chronic radiation sialadenitis happens weeks to months after exposure, which is progressive atrophy and fibrosis. So chronic form is irreversible fibrosis and functional loss, which leads to lifelong xerostomia, taste alteration and dental complications. So for that, what we can do for xerostomia, we can give saliva substitutes, Silobox like pilocarpine. For oral discomfort, we can prescribe frequent water sipping and sugar-free gum. For dental caries, fluoride gel and regular dental care, and secondary infection antifungals such as Nystatin can be given. So the salivary irradiation for head and neck cancers might cause an acute reaction as well as a chronic one. The chronic is not irreversible, and the patient has to take all the measures to reduce the effect of the salivary xerostomia and other impact for lifelong treatment. And now about the infectious lesions. There are acute bacterial infections, chronic bacterial infections and viral infections, which is the mumps. So in acute bacterial sinusitis, sialadenitis, we have Staphylococcus aureus and Streptococcus viridis as the main causative organisms. And the predisposing factors are dehydration, ductal obstruction, poor oral hygiene, post-operative states. The common site is parotid gland. The clinical findings are painful swelling, erythema, purulent discharge from the duct. As we see here, there is a purulent discharge which is coming from the parotid duct, which shows that it is the patient is having some infectious sialadenitis. And histology, neutrophilic infiltration, acina necrosis. Treatment is antibiotics, hydration and Sialobox. And chronic sialadenitis is a recurrent low-grade infection or obstruction, and the histology shows a lymphocytic infiltration. So lymphocytic infiltration shows the chronic feature of that infection. And acinar atrophy and periductal fibrosis are seen. And when we talk about the viral sialadenitis, mumps, you can see this patient with mumps, and this is the mumps virus. This is caused by the paramyxovirus. It causes a bilateral swelling, pain, fever, sometimes orchitis or pancreatitis, and the acinar cell necrosis, lymphocytic infiltration is seen. Treatment is symptomatic and it is self-limiting. So the infectious lesions of the salivary glands are seen. And when we talk about the obstructive lesions are mucosal, mucus retention cyst and granula. Mucous extravasation cyst, that is mucosal, which is a pseudocyst. It is most common salivary pathology, considered to be of traumatic origin and involves the ducts of minor salivary glands. Most involved site is the lower lip, buccal mucosa, palate, cheek, floor of mouth. It has a raised circumscribed vesicle with bluish transparent translucency and may rupture to release thick mucinous material. So normal minor salivary gland tissue is usually seen along the poorly defined pools containing faintly eosinophilic mucinous material called mucilatus. One or more dilated ducts may be present and sometimes a breach may be seen in the duct and sometimes inflammatory infiltrate is seen. So this is a clinical picture of a mucous extravasation cyst, and the histopathology which shows the extravasated mucous material here and the serous acinate here. Here we do not find any epithelial lining, so this is a pseudocyst.